Welcome to our now annual debate. Always fun, always enlightening, always entertaining. Where four brave people will come to the front and in 2.5 minutes in their initial go-arounds and a minute in the conclusion, will give you your take on an important question of the day. Very important to say this now, and we'll say it later. These debates usually have one kind of downhill side and one steep uphill side, especially in this room. So we have really brave people who are taking the negative on this one. And just to be clear, we've assigned them the roles. They have bravely volunteered. This is an exercise in cognitive dissonance. Don't expect them to believe everything they say. And if they did, you probably wouldn't want to know, because they have to argue a proposition on this. The debate itself the topic is, be it resolved that public performance data should be publicly reported. Now, this will strike some of you as an utterly absurd topic for a debate, because why wouldn't it? Until I tell you that this morning I did a systematic review of how the public uses data, and one recent survey from the United States revealed that 24% of people sometimes or often use astrology to make important decisions. So it's not necessarily the evidence-seeking world that we may have thought in the quality improvement era. Also, the interesting part of this is that it's a bit of a loaded phrase. What is performance data, and how do we use it to advance quality care? Implies an understanding of what performance means, implies an understanding of what data means and what data is and whether we have it. And it also implies that there is some process by which making it publicly available is going to improve the quality of care. So if the proposition is it's got to be used to improve the quality of care, it's a little bit different than saying it's an entitlement because it's there and we have a right to know. So maybe not the slam dunk that you thought. I think there's a subtext in the debate, although I can't say for sure. The subtext being that, that we're putting the proposition about the public should have this data because there is widespread belief that providers don't use it, so someone ought to. Oh, are they paying attention? So, there's lots to talk about here, and we have four outstanding debaters, and I would invite them to come forward all at once, and I'll introduce them all at once, and then we will get the show on the road. So, on the for side, we have a person who needs no additional introduction. If you've been paying attention in the conference, Jeffrey Braithwaite is back with us, a professor from Macquarie University, and given that he is the head of a massive research enterprise and whose life is data, we thought we would give him something relatively compatible with his life so he wouldn't have a complete breakdown mentally by having to, in essence, argue against his own existence. And he is ably supported by Tamara Komuniecki, who is a patient partner at Patient Voices Network and also a council member of the BC Patient Safety and Quality Council. I learned, among other things, that Tamara, this is the highest compliment in praise I can give it. She actually studied Latin at university. So I declared her the winner of the debate right there. So way to go. As I said to her, res ipsa loquitur, which means the thing speaks for itself, folks, in case you don't know any Latin. Mine ceased at grade 10. On the negative side are, let's face it, the people with the guts here. They have to argue the proposition that it's none of the public's damn business. So our first debater is Ahmer Karimuddin, who is a specialist general and colorectal surgery at St. Paul's Hospital, and he's the co-director of the General Surgery Residency Program, University of British Columbia. So not only is he a surgeon whose data may be shared, but he's also, as being head of the program, probably a big advocate of evidence-based medicine, only now has to argue that it shouldn't be shared. And his cohort, even more ironically, is Maria Judd, the Vice President for Programs of the Canadian Foundation for Health Improvement, whose motto is essentially evidence-informed change, and the subtext being patient-centered care and public engagement. So I think we can probably infer that maybe Maria's argument will not be heartfelt and sincere in her own mind. But these are two brave souls who will be arguing at this point. So again, welcome them because they've taken on a tough job. All right. So the format is pretty simple, but I will ask the debaters to remember, it's pretty rigorous. In front of you, the debaters, is the 2-minute and 30-second clock, which will count down when you start. I might cut you 5 seconds of slack if you're in the middle of a brilliant argument, but that's it. So no cheating on the time, and 2:30. So what we will do is we will go affirmative, negative in the order that the teams choose. Then we will have the 18-minute moderated session where I will ask respectful and probing questions that draw out the genius of their arguments and make fun of no one. And then we will have, at the end, 1-minute final statements from each of them. And then we'll have a final vote from the audience. Before we begin, I'm going to ask you the usual question, which is, right now, on the proposition that public performance data ought to be made available to the public to advance quality care, how many of you are inclined to support the affirmative? Okay. How many of you are inclined to support the negative? Well, as I said to this team over here, you actually, this is good news for you guys. You have room to grow. You have to hold on to your constituency. So it's a tough battle. All right, the ground rules are clear. Let the games begin, and over to the first affirmative speaker,
Tamara.
Thank you very much. Can you hear me all right? Excellent. So good afternoon, Mr. Moderator, honorable opponents, ladies and gentlemen. We're all here today because we're involved in healthcare in some fashion. I myself am very experienced in this regard, having been diagnosed with juvenile rheumatoid arthritis when I was 6 years old. So that was 41 years ago, and my disease has been active, and I have been advocating ever since. And I'll add that I am managing a particularly nasty flare, so if I go off the rails, I'm just blaming the prednisone. So let's start off by agreeing on one thing. What is the main goal of healthcare? I think we all know it's to improve patient outcomes. Now, outcomes improvement cannot happen without effective outcomes measurement. And I'll add to that, it should not happen without effective outcomes reporting. So what are the outcomes that we're measuring so we're all on the same page? These are words we have all heard before and work on every day. Things like access and wait times, morbidity and mortality rates, the safety of care, such as the rate of hospital-acquired infections and sepsis, the length of stay, readmission rates, patient experience, effectiveness of care. And there's one that I don't think we talk about enough, which is the effective use of medical imaging, because in my experience, doctors throw out x-ray requisitions like it's candy at a fair, or your Oprah on the giveaway show. You get an x-ray, and you get an x-ray, and you get an x-ray. So the big question is, why measure? Well, data, when properly contextualized, let's remember that, when interpreted and when adjusted to account for variables, all super important, it's not just data for data's sake, can be a powerful tool in achieving the quadruple aim of healthcare: to improve the patient experience of care, to improve the health of populations, to reduce the per capita cost of healthcare, and to reduce clinician and staff burnout. But the last big question and why we're here today is, why make the data public? To answer it quite simply, it's because I am putting my very life in your very hands. I demand access to the information that can help me make the most informed decision about who treats me and where. If a physician or a hospital is performing badly, it should not be hid behind a veil of secrecy. I should know who and what I'm getting. Healthcare should not be exempt from the concept of buyer beware, to say nothing of the fact that the Canadian healthcare system is a public system, and so you and I are paying for that with our very tax dollars. So here's the clincher. If the data isn't public, then I'm going to find whatever information I want, and it's probably going to be on the internet. Do you want that? So ladies and gentlemen, what do we want? Risk-adjusted data. When do we want it? Now. Thank you.
Thank you. All right. Well, props to you and to your props.
So public disclosure of performance information has evolved internationally over the past 2 decades in the quest to improve accountability and performance in healthcare. This trend is apparent in both publicly and privately financed systems. Despite the growing efforts in the past 20+ years in many countries, there is still no evidence that publicly releasing healthcare performance data advances care. And in fact, the dissemination of data can be misleading to policymakers and potentially dangerous for the patient and public. My understanding of healthcare has come through my work as a clinician, as a researcher, as a community health center board member, through various roles at the Canadian Foundation for Healthcare Improvement, and as a parent. I care deeply about improving systems to enable better care and health for people. And I understand that a health system is much more than a system. At its heart, it is the people who work in and are affected by it. To advance care, we need to ask and understand and measure what matters to individual patients and providers. Change Day in BC does just that, focusing on what matters to me for those who provide and need care. Data reported to the public without context can be confusing. Exhibit A. From ARC in the States, this is the quality, physician quality and efficiency. Is that meaningful and helpful to you? Take it, for example, the 4-hour ED wait time target made very public in Scotland. I'll return to that later. Authors of a recent Cochrane systematic review published just this past September searched the literature for studies evaluating the effects of publicly releasing healthcare performance information. They found 12 studies that analyzed data from over 7,000 providers and over 3 million clinical encounters. They found the evidence that publicly releasing performance data led to little to no difference in the services that patients chose, in the decisions taken by providers, and in overall provider performance. I want to be clear up front. We are for meaningful measurement, transparency, and shared decision-making to advance care. We are against this motion and this notion that making healthcare performance data public will advance care, because experience and evidence over the past 20 years has shown us that it doesn't.
There you have it, folks. An evidence-informed statement about withholding evidence. I love it.
Of course, we should have publicly available performance data. Look at it this way. Whose health system is it? Canadians. So whose performance is it? The clinicians and the citizens of Canada receiving services from them. So whose performance data is this about? The citizens of Canada and their care. So how could there possibly be a case that you'd keep the performance data from them? It's their data. It's about them, it's on them, it's by them, and it should be providing data for them. The other bit of the question is whether performance data will advance better care. Well, who said this? Healthcare remains a cottage industry of autonomous clinical and managerial decision makers where bad practice costs more than good practice.
A genius.
Lewis, 2007. In Healthcare Quarterly. And who said this in the American Journal of Surgery? American Journal of Surgery in 2017. For rectal cancer patients in British Columbia, Canada, being treated at an HIV is associated with several quality indicators linked to better patient outcomes. And who uses publicly available data every day of her existence? But you can actually answer this debate by sheer logic. Isn't it obvious that any human system, if given information to the people who need it, will use it, respond to it, increase their understanding of it, try to improve on the basis of it? For example, think about Fitbits. Who's got a Fitbit? Think about mobile phones. Think about the speedometer on your vehicle. Every one of those provides you the opportunity to make more steps, regulate your speed, find your way about the world. Data is crucial. It provides people with feedback to change their behavior. Isn't that what we want?
Right. Thank you. Well, that was quite the exercise in throwing our past in our faces, but Mueller has nothing on him as a prosecutor. Right. And to our final over here.
Thank you very much. In this era of ever-increasing data and information, it probably approaches Trumpian levels of hubris to claim that transparency in healthcare performance data will somehow not lead to better care. Some of you might say that I am a surgeon, so I guess I'm entitled to that kind of hubris. To which I would respond, I am but a colorectal surgeon, working truly in the heart of darkness where the sun doesn't shine. So what I do know as a surgeon, though, is that patients in today's healthcare climate are faced with complex, life-changing decisions every single day. Less than 70% of patients understand the information provided for even simple surgery, like carpal tunnel surgery, while comprehension around cancer diagnoses and treatments hovers at around 30 to 40%. In this world of increasing information and data density, are we proposing an ever-increasing inundation of society with decontextualized performance data? If our focus in 2019 is to improve each individual patient's experience, regardless of background, socioeconomic status, race, gender, sexual orientation, where in the province of British Columbia that they live, should we not focus on personalized, purpose-driven care to improve their outcomes and experiences and support their decisions, rather than complicating the situation? Or would my colleagues debating this motion propose that we then drown society in healthcare data, mystifying healthcare, pushing patients and individuals closer to decision paralysis around the most important events of their lives? In an extensive review done by the NIH in Italy, they demonstrated that public reporting of healthcare outcomes can be demonstrated to increase socioeconomic and racial disparities in healthcare provision, reduces access for complex surgery, specifically for patients in rural and remote sites. Is this the healthcare future we're envisioning? I fear for Australia if this is what Australia wants to propose under Mr. Braithwaite's care, Dr. Braithwaite's care. Where those with educational, financial, siloed privilege receive better and timely care, while the rest of us drown in a tsunami of decontextualized metrics? If healthcare performance data was a simple panacea, would the Agency of Healthcare Research and Quality have an 85-page high-level document on implementation? I am against this motion, not because I fear transparency, but because I value and prioritize precise, personalized, patient and family-focused healthcare decisions. The care all of us in this room provide in our patients can be turned into a tsunami of bits and bytes. I am against this motion because our patients are human as their care providers. I am against this motion because someone I truly admire, someone with whom it's a privilege to share this stage, was profoundly against this motion when government plans for public reporting of performance data in healthcare, the case against.
Well, that man is going to be the first editor of Consumer Non-Reports. That was brilliant. Not that I'm judging. But you can see it's not so simple, this allegedly slam dunk motion. So now we're into the part where we actually try to probe a little bit and increase our understanding of these complex issues. So for the next 18 minutes, I'm going to ask the presenters to go a little bit of back and forth, probe them a little bit on the arguments, some of it a little lighthearted, some of it actually serious, and we'll see if we can tell the difference. So turning to the affirmative side, it does seem to be a bit of a challenge that there is astonishing public capacity to misinterpret just about anything. Numeracy is shrinking. We do seem to have a bimodal world where there are a lot of very sophisticated people, statistically and numerate, most of whom are in this room. And there's a whole bunch of people who have difficulty reading a bar graph, and the best efforts to present information on which they should be maybe making some decisions has zero impact at all. So what's your response to that? Is that a temporary phenomenon that's remediable, or is that just built into the nature of the beast?
I worry when we're worrying about a portion of the population who might misinterpret something, because there's a whole bunch of us who don't have that problem, who should not be not granted, who should be denied the access to that information because somebody among us might not understand it. I'd like to thank my friends on the other side of the aisle for echoing some of the terms that I was using in my opening statement on that thread. Things like meaningful measurement and transparency and decontextualizing. That's exactly what I'm calling for. And they actually made my argument for me. So thank you.
Great. So, to our surgeon. I'm a patient. You've got a surgical department. There's a threefold variation in mortality rates in the kind of surgery I need. You know it, your colleagues know it, and I don't. Fair?
So I think it is exactly that entire chain of events that leads to the comment that was made earlier, oh, you should share this data publicly. Great, let's go ahead and share that data, further confuse our patients who are trying to make important healthcare decisions, and then lead to this siloing of care where suddenly hospitals will say, well, you know what? I don't want to provide care for those complicated patients because they'll make our outcomes look bad. So you have to now travel from Vancouver to Toronto to get this care done because we've decided in British Columbia that we can't provide this care because of the hoopla that's been created around letting loose performance data. My esteemed colleague and my partner, my patient partner on many of the works that I've done, spoke about, some people can understand this. Well, in Canada, healthcare literacy levels are approaching, about 50% of Canadians have healthcare literacy that's below grade 3.
Source, please.
So it's not a small number of patients.
Source, I demand a source.
Which actually, right here.
Oh, your iPad. Oh, good, thank God.
I want to buy one of those.
Which actually,
Wow.
which
I
actually
feel so much
accentuates the very privilege that I was speaking about earlier, that this kind of healthcare performance data may support the care of the 1%. But for the remaining 99% of us who aren't able to contextualize that data and understand how to utilize it properly will then suffer the consequences, as multiple reviews of this data have shown.
Very convincing, but I don't think Ahmer writing notes on an iPad 2019 is a credible source.
So, Jeffrey, let me turn to you here
I
about...
can provide a source, by the way, if that's required.
I do, well, you can challenge the evidence, but I think it's pretty well understood that, if anything, it's been a disappointing uptake by the public in doing anything with the performance data, even if we concede it might be well understood and it's clear and it's unambiguous and it's properly adjusted. That suggests, in fact, that there isn't a big public appetite for this. A, do you buy that? And B, what do you make of it?
That's one of those arguments that you just have to refute. This is the Canadian health system without transparent data. This is the Canadian health system with a little bit of transparent data. And this is the Canadian health system with transparent data. Which do you prefer, audience? And don't say when I had my bag over my head.
But, I mean, with respect, that didn't quite answer the question.
Who says we have to answer the question?
That's fine.
Whether one prefers it or not is an intrinsic principle. Are you concerned about thus far the very little use of these data by the public for any meaningful purpose?
Yes, I am. But let's just tease this out. The availability of data, making it available, is different from the development of systems and the encouragement of health literacy and the journey we are on to try and produce good data for all. Health literacy is a journey, not a destination. And all of us is smarter than some of us, so we all benefit. The tide rises across the country if we make data available in a transparent way.
You got 3 aphorisms in one sentence. That was great.
bad.
That was a linguistic triumph.
Stephen, can I bring us back,
Yes.
back to the motion? Because we're not actually talking about withholding data. The motion really is that making healthcare performance data public is the way to advance care. So I think we all agree, as you said earlier, Tamara, that the main goal of healthcare is to improve patient outcomes. We're not arguing for withholding data from the public. We're arguing for meaningful measurement, meaningful data that is personalized, that helps people, patients, families, caregivers make decisions in conjunction with their providers. They're going to lead to better experiences and outcomes. So on that, we all agree. So in the terms of the motion, this motion is about the magic bullet, my interpretation, the magic bullet here to advance care is making public performance data public. And if we look at the way that currently we look at performance data and make it available publicly and the uptake on that, I think we have to ask that as a serious question. So let's be clear about what the debate is about. It's about the motion about healthcare performance data being made public is going to really advance care.
See, I read the, well, I think we on this side of the aisle read it in two ways, that it could be healthcare performance data from a system level or a hospital or an institution, as well as a practitioner. So healthcare performance data of the very physicians that I'm dealing with every day is not actually readily available. So if I can kind of narrow it down in that, in this argument, how am I supposed to find out how my doctor has been performing? That's not a readily available set of data for me unless you want me to look at ratemds.com. Probably not.
Well, this is a great exercise in co-design. Each of them would like the motion to read in a way that they are sure to win it. So I like this. This is a creative group.
It's called a
So
debate.
back to you, Doc. You sort of presented this nihilistic scenario whereby releasing specific performance data would drive institutions and physicians out of the business because they're terrified of the results. So they've been releasing surgeon-specific outcomes data all across England for years. They're still cutting open, and people are still going, and none of this, the sky did not fall anywhere except Brexit. But that's not because of that. So what do you say to that?
So I think just to echo what my collaborator here has said, my partner, is that contextualized data, when used to provoke change, is extremely meaningful and extremely important. When a lot of the work that I've done has revolved around enhanced recovery, where again, we rely on contextualized data that's at the provider level on a daily basis. The challenge, though, is that what is your intent to do with that decontextualized data? If it's to put somebody on the front page of the paper, well, that exactly gets to what the Cochrane Review, when they looked at this issue, spoke about, was that this kind of work leads to decreasing engagement of healthcare providers. It leads to burnout in healthcare providers because they feel that their entire life, their professional work, and their worth has been reduced to bits and bytes. Is that what we want to turn each of us in this room to, and all of our patients, into this conglomeration of bits and bytes so that we can become part of the Facebook, Google, Amazon generation as opposed to being personalized healthcare providers for each of our patients? I think we need to create a healthcare system in which we can trust that esteemed practitioners like Dr. Cochrane, are sitting across from me, will be able to take the data that's given to them and work with their institutions to drive that meaningful change. So I'm not against meaningful data and sharing it in any structured way. It's just that what is the intent of that data? If it's to make things better, go for it.
I don't think you should implicate Doug in your argument.
He's always implicated in everything that I do.
So, are you persuaded by any of this? Like, do you find that as a patient, that somehow having this data would compromise your trust and sully the doctor-patient relationship and make it appear less person-centered?
As a matter of fact, it would strengthen it, I say. My argument is that I don't know enough about my doctors and about their results and about their history because I can't find the information readily. But I do want to ask, the other side over there has been talking about all the information that is out and available and that there's no public uptake. Where is it exactly? Because I've been looking and I have seen a few websites like ChiHi, for instance. I know that there's a lot there, but I'm a journalist and I do research and I couldn't find very much that was out there. Am I looking in the wrong places?
It's interesting you mentioned ChiHi. You know, I'm from Ontario, and as you may know, there's a lot of change going on in Ontario thanks to Doug Ford. And, you know, moving towards a super agency. And there was even an article in the newspaper this morning saying, you know, one of the real driving forces for this big change and changing our regionalization structure in Ontario is the amount of money we spend in administrative costs because of this regional structure in our LHINs. And yeah, quoted in that article, public reported data, ChiHi says actually after BC, who spends the least amount of money, Ontario is the next lowest in cost. So clearly that public reporting is not driving, from a policy perspective, the kind of change that is evidence informed. So just reminded me when you mentioned ChiHi there. I think for me, I distinguish when I'm thinking about this debate and the motion, back to the motion, the difference between public and to my colleague's point, where we lose the context of what that data means, who's involved in that data. This is a quote that comes to mind. People talk about statistics being, you know, human beings with the tears wiped off versus patient data and those of people in the system providing care, needing care. So we have a bit of a divide and I think a difference in viewpoint there, but where we agree is the importance of meaningful measurement and transparency and the goals of data being one tool in helping to improve care.
So Jeffrey, think about, let's supposing we said, that even on the affirmative side, that this could be a lot better. It could be a lot more impactful. So what does publicly available information 2.0 look like?
So it looks like patients and clinicians working together, co-designing their care plan with data in the middle of it, probably on an app, but good data in a timely way available so people can make good decisions jointly. We haven't got that yet, but that doesn't mean to say we're not heading in that direction, because I think we are.
Now, again, I'll ask either of you, do you see, and I don't know if you're arguing for this, but if you go to the level of, assuming it's statistically robust and well-adjusted, individual level performance reporting in some cases, like surgeon-specific mortality rates, does any of that make you a little queasy? I mean, or do you have any empathy for the surgeons, for example, whose performance may be revealed by this? And let's say there is a statistically meaningful difference in performance, but it's all good. But the public is going to say best, worst. I mean, league tables are the spirit of the times, right? People rank, people rate, you're the bottom, therefore you suck. So is there any part of that narrative that gives you any empathy, or do you say, grow up, tough it out, that's life?
Well, I think it's a bit different if you're asking me what if I was looking into my surgeon in particular and their rates of mortality. Because if we look at something like Yelp or ratemds.com, which is awful, but it's out there, patients and people have an opportunity to give a review of their service. And what would be maybe a better system moving forward is if there was something that was negative that was in a surgeon's history, perhaps there could be an opportunity to explain what happened or to provide some context. So yes, that information is out there, it's publicly available, but we also have attached to it an explanation of what happened. Perhaps it wasn't, maybe there was 5 cases of sepsis in one hospital in one day, but maybe we can, draw it back to maybe there was an instrument that wasn't properly sterilized and it wasn't actually a surgeon or a doctor who was responsible for it. So what we're talking about contextualized information, but also I do want to open it up to have more of a conversation, to have more feedback from hospitals, from caregivers, so that the patients can know exactly what happened in situations and with caregivers. Very rambly.
So over here, is there any circumstance under which, if this were done as you have been suggesting it, could be done, but isn't now, fully contextualized, responsibly and in a fully informed way used, that would make you less hostile to the proposition?
So if you walk around my institution at St. Paul's Hospital on 10th floor, Maria, Darren, hi, you can walk around and you will see that we actually have statistics on our wound infection rates, on our urinary tract infection rates, on length of stay, plastered across all the walls. And because the idea is to share our information and to make sure we do work well together. The trouble is that when you release reams of decontextualized data, which occurs in this, for example, in the States, there's an article in Health Affairs 2015 that was also quoted in the Harvard Business Review that looked at 27 hospitals that were ranked by one ranking service, and they had a rank from 1 to 27. And the other ranking service had the list almost completely flipped, all because they prioritized different aspects of the publicly reported data. So unless you've contextualized that data and you've realized what is important to you, how is the public, or how am I even as a surgeon expected to interpret that or move with that? The only way to live with that is, as you said it, as we've been saying, you need to provide the specific contextualized data to the individual patient in the context and the disease state that they're in. Yeah. Which is really hard to do and may be done in the future, as Jeffrey has said on that other side. We can find ways of doing that, but those ways don't exist yet. And despite 20 years of performance data.
But isn't that the same argument as, on that argument you would say we shouldn't have any libraries because some kid could go in and take 3 books off the shelf and make a bomb. People can misuse all sorts of things, so is that a sufficient reason for not putting it out there, even with all of its warts?
I think we have to think about how we put it out there. I mean, another cautionary tale, for instance, comes from Scotland, the very public reporting and target of people coming to the ED will wait no more than 4 hours. So in speaking to a friend and colleague who works in the ED in Scotland, he says, that came into place. It's posted on our website, very public. It's supposed to drive improvements in care. And I noticed this shift where patients who've I clearly observe are much more acute and distressed, who need to be transferred up to the ward, are not. And there's other patients being transferred up ahead of them. What is going on here? And I speak to my colleague and my nurse is saying, this person's coming up on the 4-hour wait. We've got to move this person along. So it's affecting care in a negative way because we put this public reported target of 4 hours out there with missing the context of the art and the science of medicine and care and assessing who's in front of us and what does good care look like right now.
Any uptake on that notion? So the argument being that it's the implied argument, at least I've inferred, is that it's not well done now. It's a blizzard that's not thoughtfully put out there, and the context isn't sufficiently explained, so that it's just basically nuisance data, or like that chart that you put up there with a zillion scatter dots of modest meaning. Do you buy any of that?
Some of it. We agree that data that is contextualized is very important. But the alternative, if a system is pushed to the extreme of not giving any data and having a veil of ignorance, isn't tenable. We have to try and improve what we've got and contextualize it, as our opposition wisely says. But that's not a reason for not moving in this direction.
Well, thank both of you. That was great elaboration, and I think we're actually oozing towards some common ground here in the debate, though we will, of course, urge you to vote at the end and declare a winner and a loser so someone goes away humiliated. So we have 1 minute each for summative arguments. We'll start the other way this time, so to the negative.
Measuring what matters to the public, to patients, to families, to providers, and policymakers is important. We need to use data to support patient and family-focused healthcare decision-making to advance care. We need to understand, we need to measure, we need to report on outcomes that matter to patients and providers. We need to pay for care that delivers experiences and outcomes that patients value. This is the way forward to advance care, not making current performance data public. So just to reiterate, we are for meaningful measurement, transparency, shared decision-making to advance care. We are against this motion and this notion that making healthcare performance data public will advance care, because an experience and evidence shows us that it hasn't.
Thank you.
Thank you. I'd like to open by saying data, potato, potato. We've been saying different things, but the same thing. So listen, it's not impossible that the provision of sharing data could lead to unintended negative consequences. I grant you that, but this is why we need to do it right. And on this, we've agreed. So we're actually saying the same thing. What I'm saying is that I'm not advocating for data's sake, but done right. I'm also advocating for helping me find the damn information. So when we're going to be reporting the data, making it transparent, readily available, using the tools that are available in the media for widespread dissemination would be much appreciated from this patient, certainly. And from a larger standpoint, institutions can demonstrate that they can learn from the data. If there's something negative that has come out, it's not a matter of hiding from it. It's a matter of publishing it and showing that they can pivot, learn from, not mistakes necessarily, but learn from situations. And why? Again, to improve patient outcomes. We must always come back to that. I ask you as a patient, and I ask you as someone involved in the system who wants to help other patients.
Thank you. Great.
I began this debate by stating that I am a single, simple surgeon. I talk to my patients. I'm not single, actually. I have 4 kids, and I'm married. My wife will be very upset if she's watching live right now. I talk to my patients, I explain their diagnoses, and I take the evidence of the interventions available and provide them with my most sincere advice, given my understanding of their situation and circumstance. What I do know for certain, that if there was a treatment or intervention that did not offer any significant benefit after 20 plus years of clinical experience, increased or aggravated inequities in healthcare and access, alienated care providers and confused patients, I would not offer that intervention to my patients. If all it would take to make healthcare great again would be to build a wall, I meant public release of healthcare performance data, then wouldn't multiple Cochrane reviews and the NIH Italian review have captured that? It isn't that simple, because healthcare delivery is a complex, almost chaotic process, almost impossible to capture in bits and bytes. I stand firmly against this motion, despite the compelling comments made by our opponents, which actually support our against position multiple times, because I firmly believe our patients need humanized, personalized information and data. Healthcare performance data should not be public because that will not advance healthcare. Thank you very much.
All right.
To the contrary, we've heard from erudite people with decent day jobs. And it's not their fault. But everyone knows when they've heard a good argument. But unfortunately, what we've heard, I repeat, it's not their fault, felt to me the force of the argument was a bit like being hit over the head with a warm lettuce. Or even an egg sandwich. The opposition, in fact, remind me of why motorcyclists must never grin while cycling fast, because the insects stick to your teeth. I always take notice when an entire country's health ministers agree on something, in my country and yours. The Canadian health ministers all agreed that a set of indicators for Canada is a very, very good thing. They're from the government. They're here to help us. I think we should go that way. Thank you very much.
Thank you all. All right. Well, stirring and ably fought debate and great insights, great wit, and we'll look for your profile on Tinder unintentionally. So, now we're going to do the voting, but what we're interested in is impact. And I'm going to ask you if you have changed your minds, the hardest bar, the hardest ladder to ascend in a debate. So who if you previously thought...
Stands for risk-adjusted data.
That's our side of the argument.
So who has changed their minds from original position in favor of the affirmative, that it should be openly, publicly reported to advance right? Who's changed their minds to the negative side of this after hearing the debate? Hey, guys, and who has gone in the other direction? That is from we don't want it to, yeah, we want it. Open. Well, room to grow, room to grow. I have to say that was a spectacular achievement on your part, and it by no means diminishes the genius of your argument. So I'm going to say that we are all winners for having witnessed this wonderful debate. I want you to join me in thanking these fabulous participants in doing this. It was totally great.